And so we're still talking about shoulder instability. Taysom, why don't you take this one?
All right. So I think there's an avulsion of the inferior glenohumeral ligament
Okay.
from the humeral attachment.
Okay. So that so the patient actually injured themselves playing badminton, if you can believe it. That was a pretty tame sport before I saw this case. And what do you think here?
Um, guess there is some injury to the anterior inferior labrum, but I still think that tissue bunched up.
What's this?
Has to be glenohumeral ligament, all right? Like
Yeah, the sagittal.
dislocated
What do you
medially.
see here?
I see that band of low signal tissue right there, which still makes me think it's IGHL.
Okay. So this is playing badminton, believe it or not. So this is a Hegel lesion.
Yeah.
And the patient had hemorrhage into the joint space. And as I think I've said before, it's rare to get clots in the joint space because the joint fluid uh, basically dissolves the active agents of clotting before they can concentrate enough to actually create a clot. But this is an interarticular clot from hemorrhage after a Hegel lesion.
Okay.
All right, so we have a 51-year-old with shoulder dislocation during bicycling. Uh, Again, looking at that inferior glenohumeral ligament, looks like it's not uh, attaching at that humeral there, so I think that's torn.
Hegel lesion, probably some chronic disease here as well with a lot of thickening.
Hmm.
And then you also see the acute bone injury here. So this is probably an inferior dislocation with the superior Hill sacks and then a tear of the inferior glenohumeral ligament.
Hmm.
Great. And also some injury to the, let's see, there's some other things here. So there's probably a tear here of the, oops, a bit of the supraspinatus. And then here, probably an injury here to the anterior labrum as well. And this just shows when they went in there, they saw a lot of defects. So it's a Hegel with a greater tuberosity fracture, supraspinatus tear, and a labral tear, which was all confirmed at surgery.
Okay, so here, looking in the posterior joint, there's kind of this lax tissue. Could be that.
Like some fluid outside the capsule here.
Mm-hmm. Could be a posterior capsular tear or another inferior.
Look like it's coming off the humerus.
Mm-hmm.
And so this is really a posterior Hegel, or what a lot of people call a reverse Hegel,
Okay.
which is posteriorly rather than anteriorly, where the typical Hegel is.
Okay.
So we see that torn tissue near the inferior labrum, and there's some joint fluid exiting the joint. So
I
that's
can't quite hear you.
oh, that there's some joint fluid outside of the joint space, and so this is probably a like a glenoid avulsion of the glenohumeral ligament.
Yeah, this is one of the reasons I really don't like arthrography, because you don't know whether this is just a bad injection, which we see all the time, or whether it's actually a significant soft tissue injury. So especially after trauma, I really don't like doing arthrography. Arthrography is fine, and if you're dealing with kind of a non-traumatic concern about labral tear in a young athlete, but I really think that you should restrict doing arthrography. In the setting of acute trauma, I really don't like it. It can mask or confuse muscle tears and other significant injuries. So, but here we can see this is the inferior capsule coming around here. Inferior glenohumeral ligament, probably the labrum, which is pulled off, and we can see an inferior labral tear and probably contrast extending through that tear out into the soft tissues on the injured side. And this is what it's supposed to look like, which is this patient's opposite side. And this is typically called a gaggle lesion, but I don't know. I'm not a big fan of these kind of terms, so I think it's best just to describe it. John?
Makes no sense to do both sides and then use dye also. That's just silly.
Yeah, we see that not infrequently. I agree with you, John, but it certainly is nice for lectures. Okay.
All right. So I think there is an avulsion of the glenoid attachment of the inferior glenohumeral ligament, and then probably a labral injury with a paralabral cyst as well, right?
Yeah, so this is another one. Here it's kind of nice you can also see that this is contrast extending into really a paralabral cyst here. But a lot of these paralabral cysts, the fluid, it looks like fluid in it, but in reality, it's a gelatinous structure because a lot of the water gets resorbed. And you can see where the contrast is kind of slowly diffusing into this gelatinous structure, which is inside the paralabral cyst.
And would you say there's a lot of protein in there or
Yeah, probably.
All right, so we have a coronal. Looks like there's a lot of edema on that superior kind of lateral aspect of the humeral head. And then looking at the inferior glenohumeral ligament, it looks thickened and edematous.
Right. And torn.
Yeah.
And then we can also see that there are other labral tears here in this particular patient as well.
Okay, underhand ball player, right shoulder pain. So looking at the inferior glenoid, there's some irregularity there, some bone fragments. The humerus itself looks okay. So here on MR, we see in the top right image, yeah, torn IGHL. And yeah, there's some, I think, some bone fragments as well off the inferior glenoid.
So you can see here. So this is called a bagel lesion, which is a bony glenoid avulsion of the glenohumeral ligament. So this is just, we have a bone fragment that comes off with it. Okay. And it just shows how close these are to the axillary nerve. Okay, well, let's go on now to the superior labrum. And injuries to the superior and anterior superior labrum are, by some people, are called microinstability. And the person who popularized this was an orthopedic surgeon in Orange County who's, I'm really sorry, name I'm blocking on right now. And then also slap lesion, superior labral anterior posterior, which was first described by Steve Snyder at SCOI, someone who Greg Applegate has worked with for over 30 years. So Nottage, Wesley Nottage, is the orthopedic from Orange County. I think he was primarily the doctor for the U.S. swim team. It's about 6% of instabilities in his experience, and the symptoms are very difficult to differentiate from other conditions in the shoulder. So micro instability, it can be due to slap tears, which we're going to talk a lot about, superior labral, anterior, posterior tears. You also get a thing called anterior superior labral detachments, which I don't think this term is used much anymore. It's kind of replaced by slap. Superior glenoid ligament laxity or tear, middle glenohumeral ligament detachments, which is also called straight anterior instability, and articular partial thickness tears of the rotator cuff, which are very common. But most micro instability that people really are interested in today's world is really the slap tears. So slap tears, there have been a lot of papers concerning slap tears over the years. The first 4 were the original one described by Snyder. Type 1, well, we'll go through all of these different slap tears. When we get down to these high ones, I think these are people who really wanted to publish a paper, and these kind of get complicated, and there's a lot of overlap within them, which we'll talk about. So most people will only talk about the Snyder's classic 4 types. Some people will kind of include the type 5. These higher levels are mostly in the radiology literature. However, they're also in the orthopedic literature, where they are actually referred to slightly different injuries than in the radiology literature. And the type 10 here at the bottom was actually described by an orthopedic surgeon in Santa Barbara. And we'll talk about that when we get to it. So one is location. Some people, most radiologists will use the nomenclature here on the left, where the tear is at superior, posterior inferior, inferior, anterior inferior, anterior superior. Some people like to use an o'clock position, where 3 o'clock is anterior and 9 o'clock is posterior, but most people that I know have used the one on the left. So these drawings come from an article in AJR from the UC San Diego group. Type 1 is fraying of the superior labrum. It can be associated with the biceps anchor insertion, but the biceps anchor insertion is still intact. So it's just fraying up there. Here's normal. We see a little bit of recess there, a nice black superior labrum, nice black biceps anchor. And here's this was type 1 slap tear. See a lot of increased signal intensity. Most of the normal superior recesses have a nice curved appearance where they go out around with the articular cartilage. This one is a little bit straighter. I don't call these type 1 slap tears anymore. I just call these degenerative changes of the superior labrum. And I'll explain why a little bit later. So that's a type 1 slap tear. A type 2 slap tear actually involves a tear of the biceps anchor as well as fraying and tearing of the superior labrum. Here we can see a normal recess superiorly, superior labrum, biceps anchor. There's biceps anchor, there's the labrum. And here we have here's the recess. It's a separate linear high signal line, which therefore must be in the labrum itself. So this is a labral tear. See a little bit of thinning of the biceps anchor in this location. On the next cut, we can actually see a perimeniscal cyst. And so I'm much more comfortable calling these tears when I see an adjacent paralabral cyst. Paralabral cyst next to it. Now, type 2 slap tears were further divided by Morgan from the East Coast into 3 types, A, B, and C. Type A, the tear is just anterior to the biceps anchor. Type B, the tear is posterior to the biceps anchor. Type C is both anterior and posterior to the anchor. Almost all the ones that I've seen have ended up being type 2Cs. And this comes, I think, from one of their papers. This would be a type 1. This would be a type 2. Type A, type B, and then type C goes all the way over the top. And here we see posteriorly, we can see the tear within the superior labrum. In the mid portions, we can see the tear in the superior labrum with fluid going deep to the biceps anchor. And then anteriorly, we can see that there's a tear here. So this is a type 2C tear. I'm going all through this just so that you know this for historical reasons, and you may go someplace where people use these terminologies. I don't. And for years, I would try to type all the different slap tears into types, and I just don't do that anymore after the last decade and a half when surgery to this region has really decreased due to some papers that were published. Now, another type of type 2, usually associated with type 2Cs, is called a peel-back mechanism, which also came from Morgan and their group. And this is typically in overhead throwers. When you get into the throwing position where you cock the arm for throwing, you actually twist and yank on the biceps tendon, which can kind of start a tear, which can start ripping the biceps at its attachment to the anchor here. And this is called a peel-back mechanism, which can also not only tear the biceps, but the adjacent superior labrum. And it's really in this late cocking stage where this occurs, and then you forcefully go forward, where you basically fire all the muscles to maximize your fastball speed, and that includes abrupt tension on the biceps in that vulnerable position. Okay, let's see. Pavan, I think you're next.
So it looks like there's a tear of that anterior or that superior labrum, and
Yeah, we're probably a little posterior here. This is probably the spinal glenoid notch here.
okay.
You see some funny signal here. That's probably the labrum, and a paralabral cyst coming here. And posteriorly here, we can see that posterior superior labrum, common location for tears that we see that we talked about before in overhead throwing athletes due to both posterior impingement as well as the peel-back mechanism that we just talked about with a nice paralabral cyst right adjacent to the tear. Okay. Let's see, is this the same one or is this a different one? Yeah. Okay. Here we go.
All right, so 49-year-old female, shoulder pain, looking at the superior labrum. I think there is a labral tear with detachment of the biceps anchor as well, right?
Okay. What's this?
That is the biceps.
Okay. And there's the tear.
Yeah.
So what type is this?
Let's see, we're going anterior to, it's a 2,
Okay.
maybe 2C.
Yeah, I think I would call it a 2C2 because it extends really into and through the biceps anchor. Right. So that's another type 2 slap tear.
All right. Let's see. I think there may be a tear of the anterior labrum.
Okay, so
Spicy.
we're really high here. Here's the superior glenohumeral ligament.
Okay.
So we're at the level of the superior glenohumeral ligament. So this would probably be above any normal defects
Okay.
there. So I would put this in the superior labrum part. And here you can see a nice paralabral cyst. And these paralabral cysts, you commonly see them associated with anterior and posterior supralabral tears. So they can be very helpful in making you feel comfortable about confirming your diagnosis that it's actually a tear and not just a superior recess. And here we can see that cyst here. that's the edge of the cyst, and it's actually going out into the joint space, where you can see that cyst is actually projecting out into the joint space where the joint capsule is containing it here. And if you look, you can see a neck going here. And these can often extend over close to the suprascapular or spinal glenoid notches. And these cysts over time can grow and become quite large and then can compress the suprascapular nerve, producing denervation changes of the supraspinatus and or infraspinatus muscles that we'll talk about, which you always have to look for. So that's another type 2 slap.
Okay, so here, looking for the superior labrum. I think the superior labrum is displaced medially. I think that's that tissue like medial to the glenoid there.
It looks like it's kind of very medial to the glenoid. Over here,
Yes.
that's fat in the suprascapular knot.
Oh, okay.
The fat suppression. So the labrum is just very degenerated here. But we have this funny fluid collection that looks like it's outside the capsule.
Mhm.
If this were the capsule, then you would expect just it to go into the joint space. And this is an arthrogram where you see there's the joint space.
Mhm.
Here's something that looks like muscle on this T1 fat suppressed image, but on the PD fat suppressed, it's not muscle. That's a fluid collection.
Mm.
And this is actually another perimeniscal cyst from a superior slap lesion, which is just extending. The perimeniscal cyst is sitting just outside the capsule, deep to the supraspinatus muscle there. And there it is on the T2 weighted image.
Oh, wow.
There it comes.
Okay, so we have a tear at the superior labrum, and then it's at the, looks like it's at the posterior superior. And,
I don't hear.
oh, sorry, put a tear at the posterior superior labrum, and then,
And this is pretty close to the midline here,
oh, okay,
but you can see it posteriorly there.
okay.
Okay.
Um,
So here's articular cartilage. That's a dark structure there. And then we have another bright structure here. So this is probably part of the labrum, and that's a tear in the superior labrum.
okay.
Good. And then here we can see that tear going posteriorly. Not quite sure what this is. We'd have to look to see whether that's going to be a paralabral cyst or not.
Okay.
And then, but there we can see the things. In this particular case, I believe on the other images, it proved that this went back into a tear of the anterior labrum. So this again would be a type 2C lesion, goes both anterior and posterior. Kind of a classic SLAP, superior labral anterior posterior lesion. And this is on 9/26/07. Now the patient came back 10 months later, and this is what it looked like.
Mm-mm. So it looks like there's some interval, like scarring or adhesion at that superior labrum.
Here,
Yeah.
what's this?
Oh, some. It could be like.
Does that help?
Oh, there's an interval fixation of the labrum. Okay.
So this was a suture anchor repair. This is one of the suture anchors, and now it looks like the tear. There we can see the tear nicely on these. And now we don't really see the tear there, but there's a lot of kind of scarring and distortion due to the surgery. But it looks like they did a good repair here. Okay.
CT arthrogram.
Yeah, I guess there's some fluid undermining that superior and posterior superior labrum. Yeah, so I think there's a slap tear, yeah, from superior to posterior.
Yeah, see here, you could argue this could be a superior recess.
Yeah.
But if you look at the other images, that doesn't look like a recess because it goes through the substance of the labrum. And that was a type 2 slap tear on CT arthrogram. Okay. So Dr. Snyder wasn't too impressed with type 1 and type 2. He became a little bit more impressed with the type 3, which is a superior bucket handle tear, where you have a loose fragment of labrum, which then just kind of displaces a little bit out into the joint space itself and involves the base of the biceps anchor. It is believed that involvement of the anchor, biceps anchor, may be a significant cause of symptoms. So biceps anchor partial tears are considered more significant than just a superior labral tear because you've got that stretch on that biceps anchor. There's a lot of nerves in the biceps anchor, and that can be a cause of pain. So the type 3 and 4 lesions are ones that were considered important for surgery. So that's a type 3.
So can't really tell what we're looking at here.
Oh my God. So here's a humeral
Humeral
head.
head, yeah.
There's a superior glenoid.
Okay.
This is fluid.
Yeah.
This is articular cartilage.
Uh-huh.
So what's this?
So that's the labrum and biceps anchor that's displaced.
Yeah. So this is a type 3. So, the bucket hand, this is actually labrum bucket handle tear. The biceps is displaced in this particular case. So that was and then here's just another example where this could be a recess. We can see some signal change here, but this really looks very irregular in this particular case with kind of strands going through it here. A lot of abnormal signal here, maybe some straining here associated with the biceps anchor. But then when we see the axial images, we see that if this were just a superior recess, it shouldn't go out into the actual substance of the labrum, which it does here anteriorly. So this is actually the continuation of the slap tear into the anterior labrum, which makes this a tear, not just a superior recess. And this was type 3 slap tear. And then there's type 4, which was considered the most significant and the most likely to be symptomatic and a strong indication for surgery, which is where the tear actually extended longitudinally into the biceps tendon itself. So here's a case where we can see a lot of increased signal intensity, a change in morphology and signal within the superior labrum. If we look here at another, the next, well, this was in 2005. And if we come to 2008, what we see is that there is a change here. And now we're seeing contrast in this area. And we're actually seeing contrast going longitudinally along the longitudinal tear in the biceps. So this makes it a type 4. If you see this, this is something you need to put in your report because according to Snyder's and other, these are very likely to be a cause of significant symptoms and need to be surgically treated.
When he was a resident of ours at USC, he was working on the knee, and then we talked about where he wanted to go for a fellowship, and I talked him into going to my mentor, Marty Blazina, instead of going to Curlin Joe. So
You did?
so he went to the Valley.
Yeah.
It's kind of an interesting guy. pretty sharp cookie. He's well known in the literature.
Yeah, he really became very well known in the shoulder. I guess he joined Fox, right, to start SCOE?
Yeah, he joined Fox and Marty Blazina. Marty Blazina was the big guy.
Okay.
He was a professor at UCLA and a team doctor. So
Yeah,
I knew him very well.
right.
We were good friends.
Yeah. And here it's just 2005, 2008. We can see there's a lot of odd appearance here of this biceps anchor here. This is probably that superior glenohumeral ligament, which is part of the sling mechanism there. But this is in this plane that really should be more linear, not flattened like this. And this turned out to be a type 4 slap tear with longitudinal tearing of the biceps here.
Okay, so here, on the left image, I'm looking at the biceps in the bicipital groove.
Can sit here. The
Yeah.
thing here, notice this is the proximal biceps. On the
Okay.
T1 weighted image, it really should be black. On the T2 weighted image, we can see that it is a little bit lower signal, so we can actually follow it as a kind of a thickened biceps, but it's very tendinotic here with
Okay.
increased signal intensity on the T1. And this turned out to be a type 4 slap tear as well.
So we see some irregularity at the superior labrum and the biceps tendon at within the biceps, like the canal. You can't really make it out very well. I would expect some low signal there.
Yeah.
So we're probably looking at a type 4 slap tear with extension
Yeah.
into the biceps tendon.
So this is called type 4 slap tear. Nowadays, I would just call this severe degenerative disease of the superior labrum, as well as severe interarticular biceps tendinosis and partial tearing. But if you use the slap designations, then this would be a type 4 slap tear. The bottom line is when you see a lot of disease within the biceps tendon like this, it's highly likely that that's going to be a cause of symptoms. If it's not all the symptoms the patient has in the shoulder, it's certainly going to be part of the component. So it's important to recognize that because if these patients have shoulder surgery, generally they are all going to need a biceps tenodesis to get rid of this, the biceps as a pain generator.
All right, so the superior labrum is pretty attenuated. There's a focus of higher signal.
Okay, here's the next cut. This patient was internally rotated. So you can see the biceps down here.
Yeah, there's a
So the
lot of
biceps
tension
can
in
go up
the
like that.
Is it completely formed from its anchor?
No, it's still here. We can still see that I think it's there. This is that biceps. It's markedly thickened with a lot of increased signal. If we go to the sagittal images, this is what it looks like. This is just severe tendinopathy and partial tearing of the interarticular biceps.
Okay.
Typically a very symptomatic lesion. Yeah. But it's another type 4 slap. So type 5 slap is a tear of the superior labrum which extends anteriorly to involve the anterior labrum. And sometimes it's thought that these may start down here and go upward, but I think a real type 5 slap typically starts superiorly and extends anteriorly. And here's just an example. We can see a superior labral tear here. you see anteriorly, this is abnormal. There's actually a little displaced anterior labrum here from an anterior labral tear too. So I prefer calling these tears of the superior and anterior labrum rather than anymore calling them a type 5 slap. But if you work with people who like the slap designation, though I think it's much less common now than it was 20 years ago to use the term slap, because a lot of these more complicated slaps, I think were kind of shoehorned in with Snyder's designation, when in reality they're really different mechanism of injury. So I think the location and what's happening is more important than the type of slap it is. So that's a type slap. Here's another superior labral tear extending anteriorly, and you can see the tear up here, another type 5 slap. There's a type 6 slap tears, which is an unstable tear of the anchor, which I find very difficult to differentiate from some of the other types that we've already talked about. How do you know whether it's unstable or not? But here's one that was called a type 6, where you can see displacement of the biceps anchor here, where it's not completely pulled off. I don't think you see this very often, because most of the time, if you have this much tearing in the biceps anchor, it's just going to completely tear and distally retract because of the forces involved in it. But you might find a small period of time there where you can find it displaced like this. Okay. A type 7 slap tear is a superior slap tear here, which extends longitudinally into the middle glenohumeral ligament. I think these are very uncommon. But here we can see, start out here above, there's a slap tear coming down lower. And this area we're actually getting in from the anterior superior labrum into the area of the middle glenohumeral ligament here. And if you follow this farther out, this goes down to labrum, this goes out and adheses, connects to the deep layers of the subscap. So this is actually the superior fibers of the middle glenohumeral ligament. So here we can see the patient has an acute bone injury. Also looks like an injury to the superior labrum here. And if we follow it out here, we can see a lot of disease here. And then in this area, there's a lot of injury pattern. And then here, this is the anterior labrum. This is a torn middle glenohumeral ligament. So this would be another type 7 slap tears. But I would just call them separately. Nowadays, I would just say it's a superior labral tear and a tear of the middle glenohumeral ligament. And again, these are really quite uncommon. So I'm not sure it really designates a separate designation. Type 8 are superior labral tears which extend posteriorly along the posterior labrum. Now, these aren't so rare. So it's a type 2 plus a posterior labral tear. And then here's an example of a superior labral tear here. This is now going posteriorly. Superior labral tear extending posteriorly down into the posterior labrum. And here we can see it back here. And down into the posterior labrum down here. So this would be a type 8 slap tear. And then here, as we can see, a posterior labral tear here with a very deformed superior labrum here. And this was another type 8 slap tear. And then a lot of these can overlap. Here's one where you have both a 6 and an 8. I'm not going to go through all the different portions of the labral tear here because I don't really like to use these designations anymore like I did a number of years ago. But if you're interested, you can find ways to take these complex tears and throw them into different slap tears if you want. Okay, then there's a type 9, which is really near circumferential tear. It just doesn't involve the inferior labrum here. And here we can see anterior and posterior tears as well as a superior tear in this particular patient. And inferior. And here's more complex tears. Most of these type of tears that I see aren't really acute injuries. These really are more chronic injuries. And they're typically seen in people with degenerative joint disease. I like to think of slap tears, and I think Snyder's original description were really in athletes, which were acute traumatic injuries, not chronic degenerative tears. I think most of these circumferential tears are really in association with significant degenerative disease of the glenohumeral joint space, and those patients are usually more in line for joint replacements rather than arthroscopic repair.
Depending on age.
Yeah. Actually, I think this was actually described by, well, anyway, never mind. And then there's a type 10, and there are a couple of different type 10s depending upon where you read, but the radiologist type 10 is a superior labral tear which extends into the superior glenohumeral ligament. And that's in the radiology literature. In the orthopedic literature, they have a SLIPE 10 lesion, which is described as a type 2 lesion, which extends posteriorly into a chem lesion, which is posterior inferior tear. But again, here's one where the injury extends out into the superior glenohumeral ligament, into the interval. And there's another type 3 tear up here, but it extends out into the interval. I think this is just a paralabral cyst. So personally, I don't think I've ever used the term type 10 slap tear in a report, even when I was trying to type all these tears in the old days. That just is a superior labral tear with a paralabral cyst. And then here you can see them. Okay, see you next.
Okay, so 55-year-old had osteolysis in the femoral head. Needed to use a walker. So here, coronal view, looks like there's superior subluxation of the humeral head with remodeling of that acromion. Okay. Yeah, and some deformity there of that head neck junction. What going on here? Looks like so we have some contrast. So looks like we have an effusion surrounding the head with
a lot of synovitis around here, a lot of enhancement of the synovium.
Yeah.
So what's caused this?
I mean, it looks like
you can see that the rotator cuff is torn. Muscles are severely atrophic.
Looks like there was some kind of impaction injury between the humeral.
And this patient had a superior dislocation and had the torn CC ligaments, and that was from repetitive impaction of the head against the glenoid. I remember this patient had to use a walker, and the constant repetitive trauma in a very unstable shoulder because his muscles are very weak just led to a repetitive impaction between the glenoid and the humeral head. So if you don't have muscle strength, you shouldn't be using a walker.
Not a very functional shoulder.
No. And then there's a thing called multidirectional instability, where you're unstable, usually anterior and posteriorly, but you can even have inferior and superior as well. Uh, and then you have more diffuse labral injuries.
That's a capsular situation as far as
Right,
I understand it, John. So
right.
um,
Well,
that treatment that I know of is capsular tightening,
okay.
imbricating the capsule and tightening it up. But some of this is it makes you wonder what you're dealing with.
Yeah, and I think a lot of these are very difficult to treat because they just tend to have poor tissues, and even if you tighten them up, they end up loosening again.
Well, these are what I call the loosers. Their tissue is stretchy,
Yeah,
so you tighten them and then they loosen again.
yeah. Yeah, this slide I told you was going to be coming. So, one thing you can look for even in an arthrogram is the size of the inferior recess. And this is a study in radiology where if this distance is greater than 17 millimeters, it means that you have too large of a joint space and you're likely to be unstable because of capsular laxity. So they use a 17 millimeters here. You'll often see this in people who have repetitive anterior dislocations because when you anterior dislocate, you stretch these inferior glenohumeral ligaments, and that leads to increased space inferiorly here. And you also commonly get this in people who have multidirectional instability. So that's the number 17 millimeters.
And it all depends on the size of the patient.
Yeah. Yeah, in this study, I don't think they actually corrected for the size of the patient, but it would make sense to do that.
Is that something that you would put in as a measurement, or it's something you measure and then like your report is kind of like this laxity of the inferior capsule, which increases risk for instability? Is that how you would?
Yeah, I would when I think that it's abnormally large and that the patient may be unstable, I'll say that there's a large inferior recess, and I'll often give the measurement, but not always. Okay, let's see who's next.
So fall on a abducted shoulder. So we see some edema at the anterior aspect of the humeral head. It's kind of in the region of the
Sorry, what?
so bony edema at the
Okay.
anterior humeral head, and it looks like it's in the region of the insertion of like the subscap tendon.
Okay.
And then there's some high signal within the tendon itself, distally.
A little bit there, probably some tendinopathy. What's happening here?
Oh, so we see some laxity of the posterior capsule, so a capsular tear. Oh, okay, so that's probably some extension of the hemarthrosis into like the like the adjacent soft tissues
Yeah, so this is between probably the teres minor muscle,
and the.
maybe the inferior part of the infraspinatus and the posterior deltoid, right?
Okay.
And if you keep going down, you can see that capsular tear down through here.
And that's the capsule and the synovial membrane.
Yeah, and the synovial membrane, and with some extrusion of fluid out from here.
And obviously swollen because you can see it.
Yeah. So he had a dislocation, and with that, he really had a tear of the capsule back here. Good. Okay, for some reason, they thought this patient had severe instability clinically.
I don't know why, John.
I think they could be right. So it looks like there's a full thickness tear of the supraspinatus, uh, and I'm looking at a chronically torn inferior glenohumeral ligament that's calcified or ossified.
Okay. And then marked deformity of
Yeah.
the glenoid here, and severe muscle atrophy. With what's important here is you've got severe atrophy of the deltoid muscle. So there's really not a whole lot they can do here without a good deltoid.
I'd go upstairs on this one.
Yeah, and make sure you don't have a neurogenic cause of disease. So I definitely do a MRI scan of the cervical spine. Right. Okay, let's talk a little bit about. Actually, let me just think here. Well, why don't we stop here, and we'll talk about some complications of instability. See on Thursday. Okay.
Well, have a good afternoon and good Wednesday, and we'll see you guys on Thursday.
All right.
Thanks, John. Appreciate it.
Thank you. Take care.
Yeah.
Thanks for the lunch again.
Thanks, John. Yep.